Welcome to Skin of Color Savvy, the art and science of treating patients of color, the official podcast of the Skin of Color Society, hosted by SOCS leaders and produced by HCPLive. I'm Dr. Elizabeth Kiracofe. I'm a board certified dermatologist in Chicago and founder of Airia Comprehensive Dermatology, and I'm pleased to be joining you for this Savvy Conversations episode focused on a topic that is increasingly shaping how we think about care and delivery outcomes: patient power, voices driving change in skin of color care. I'm joined today by my colleague, Dr. Avery LaChance, as well as Barry Gardner. Dr. LaChance, would you introduce yourself, please, to the audience? And then Barry, would you as well?
Thanks so much, Dr. Kirakoff. Such a pleasure to join this amazing crew today. And I'm really delighted to be joining you for this really important conversation. My name's Dr. Avery LaChance. I'm a dermatologist at Brigham and Women's Hospital in Boston, where I serve as the director of our autoimmune skin disease program and director of the connective tissue disease clinic, and also lead our psoriasis and advanced psoriasis therapeutics clinic. So having a lot of these conversations about which drug is the right one for the right patient at the right time. And I think this conversation is really incredibly important. So thanks all for having me, and I'm looking forward to discussions to come.
Yes, that's why you're here. Barry, go ahead.
Yes, hi, my name is Barry Gardner. I'm here in Seattle, Washington. I am a biologic coordinator and medical assistant for Lark Dermatology. I'm also a published author and future PA student. I'm getting my undergraduate finished in August of this year. I'm getting a Bachelor of Science in Human Biology. And like Dr. LaChance said, I'm elated to be here. Skin of Color Society is I follow your organization. I've always wanted to speak for you. It's been one of my main goals. So I'm just excited to be here and be able to talk about ways that we can help patients of color and really affect change.
Yeah, that's amazing. And you have such an amazing story, Barry. I look forward to diving into that. And congratulations on everything that you're doing now and what you have to accomplish in the future. I'm sure we'll be seeing more of each other.
Yes.
And so, as the episode title states, I want to talk about patient power. And so, when we talk about patient power, we're referring to I like to think of it as a shift toward patients playing more of an active role in shaping their care, as well as the broader healthcare landscape. And sometimes when I'm in my own clinic, I'll say to patients, hey, I'm here to offer you the menu. I'm here to tell you, the pros and cons of different menu options, but you are the one that's ordering. You're the one that gets to choose. You're the one that has the power. And so, Dr. LaChance, you do so much of this with, more of our advanced medical therapies in chronic dermatologic disease. How do you define patient power in dermatology, particularly in the context of skin of color?
Yeah, I think when it comes to the definition, Barry and I were chatting a little bit about this previously in terms of patient power. I think patient power is so important through every single stage of the journey. And, I think the thing that we're going to narrow in on and hone in on today, and the thing that is becoming increasingly important, is patient power when it comes to choosing a medication, a therapeutic, when there's this panoply of options that we now have for patients, and when we're at a time in which there's exceedingly and increasingly more ways for patients to get information about medicine and healthcare outside of the physician-patient relationship. So I guess I define patient power as the knowledge, um, cultural preferences, and then also personal beliefs that are married with the combination of dialogues with physicians and then also interfacing with different tools and technologies outside of the physician office that kind of comes together to inform patient choice. And I think that's a really broad definition, but I think there's so many different factors that are impacting patient choice right now. And so it's a really complicated time, but I think it's a time that more and more we're kind of seeing that patient voice get increasingly stronger, and that we have to be ready to have those conversations in a really thoughtful and an appropriate way. When it comes to skin of color, I think certainly, and rightfully so, historically, there's been this broad mistrust in the healthcare system with certain members of the skin of color community and certain communities within the skin of color population. And I think that's founded on many years of um, combinations of science that has been unfounded and trials that were misused in certain populations, as well as different biases that have been brought to different communities of color and individuals of color. So there's this historical mistrust in the healthcare system that I think is even more important for us to be having really thoughtful conversations with our patients with skin of color.
Absolutely. And I'm really happy that you brought that up because what I think is so powerful now is that hopefully patients are not fearful of having these conversations with
Right,
us. And
right.
I think that there are a lot of us that are, more willing to acknowledge that conversation and that there is a historical underlying mistrust. And what do we do to move past that and to learn from it and showing how we've learned from it, to move forward to make sure our patients are not going to the doctor because they didn't have a good experience in the past, and that potentially negative experience in the past doesn't have to be the experience they have moving forward, because we have organizations like the Skin of Color Society that are doing everything we can to make sure that we have educated clinicians and educated patients. And you brought up, Dr. LaChance, that underrepresentation and mistrust in healthcare. Barry, I wonder if you can comment on how these historical and as well as like systemic factors continue to influence patient engagement, trust in dermatology care, and Dr. LaChance, feel free to weigh in as well.
Absolutely. And I'll definitely agree with Dr. LaChance where it really does start like to me, patient power is defined in education because that's mainly what the patients are lacking when they're coming into the clinic. I see firsthand, usually by the time a patient has come to us, especially a patient of color that has like type 5, type 6 skin, the first thing that they're saying, this is now their third or fourth dermatologist that they've now seen because they've either been mistreated or misdiagnosed and they just don't have the relevant information to know exactly what it is that they have. So I think that's really going to be the key to giving patients that power is truly educating them. And, I know we'll get to it later on, but, I think one of the big things is not throwing a lot of information at patients right at the start. It's kind of being able to you kind of gauge the patients by when they come in. So you can usually tell when you're sitting down with a patient to get their initial complaint of how long they've been dealing with it for, what things they've tried. So you can always obviously tailor, what you'll want to do based off of that. But yeah, I think the biggest thing with is just making sure the patients are aware of what treatments are available, which then helps them give that power in the decision making of what they want to do moving forward. And I do agree that a lot of this does have to do with those gaps of things that happened earlier, like the Tuskegee, studies with the black men that was 40 years, I believe. It started in the 1930s, where that's where a lot of that mistrust started because they were going 40 years without being actually treated with this condition. And so then it just kind of puts up with this wall. So when you kind of couple that with also providers who didn't have an extensive amount of skin of color in their medical texts and things of that nature. So when the patients are coming to them, even the providers are not able to 100% honestly know exactly what it is that they're dealing with. At least from my experience, I would say here in Seattle, and then also when I, travel and do speaking engagements, and skin of color will always come up in any presentation that I do because I want to see how educated the crowd is and knowing how the skin presents or how it looks. And it's always tends to be I'm not sure, but I love to educate. So I think that's where it comes in, is that education and power to help the patients.
Yeah, education is definitely the link. Knowledge is power, right?
Yes,
And that is so critical when we are, working with patients and empowering them. I think sometimes patients will come in and say like, okay, I brought a list and you probably don't like to see this, but actually we love to see that, right?
yes.
And because that tells us that our patients are engaged in their care and they want to, have that advice. And also, it shows the importance of us listening. right? And listening is such a critical and foundational piece of all of medicine and all of healthcare, but especially with our patients of color who we know that sometimes have not felt listened to. There have been studies that say, doctor interrupts a patient within 5 or 6.5 seconds of them talking. I don't remember the exact number, but we know, and it's out of like heart often, because we want them to clarify something, but the importance of just of listening to our patients. And we know it's so important, but it's also tricky to operation oper hmm, opera how do you say operationalize? There we
Yeah,
go.
you got it. That was it.
There we go. I think that
Operationalize,
was
yeah.
it. I knew the word I wanted to use here, but but we talk exactly like, listening is so important, but how do we oper I really
Operationalize.
hope we do outtakes, or maybe this will just stay in the whole thing. This is great. But you say it, Avery.
Operationalize.
Operationalize. There we go. Okay. How do we
Ah, Elizabeth.
Oh my goodness. This is one of the most funny things that has ever happened to me on a
Tim
podcast.
says he's got your
But
back.
what we want to do is operate what I want to know, Dr. LaChance, is how do you make the time taking listening in clinic possible? Because it's not like we have an unlimited time with our patients. And unfortunately, the way that healthcare is reimbursed is it's not spend more time with your patients and have better reimbursement, therefore be able to pay your staff better and add on to your clinic space. It's volume is one of the main metrics. And so when we're nope, I tried again. When we're trying to make that happen in clinic and make that possible to allow for that listening time, it can be challenging in a busy clinic. So, what do you think are some practical ways that clinicians can be patient centric and in just everyday dermatology practice?
Yeah, oof, that's such a tough conversation. I think is a battle that we're all having every single day in clinic is, well, we would love to sit there and have 1 or 2 hours to wax and wane poetic and, get to know every single patient and discuss every single thing. I think this is where the art of medicine really comes in. And in terms of Barry's whole thought with education, I think we all have to start by educating ourselves and feeling really comfortable with the different treatment options available for whatever it is you're treating your patient for. And as we become comfortable with those medications, that's where we can start to develop our scripts, if you will, and the lexicon that it takes to really present that information in a fast, effective, and efficient manner. And I think when a patient comes in, the first thing you're going to do is, of course, say, what's bringing you in today? And I think allowing them that space to say what's bringing them in today and allowing them to finish that sentence, that paragraph, can then make the subsequent back and forth be quicker because they've been heard in that early aspect. And then I think when it comes to choosing medications, as we're sitting there thinking about the disease at hand that you're trying to think about, in your back burner brain as a physician or a PA, you're kind of going through the Tetris in your head. I'm kind of closing my eyes always and, well, keeping them open, but in the back of my mind, kind of trying to meditate on what disease are we trying to treat? What are their comorbidities? What meds are they on? What interactions do I have to be thinking about? And then already you're going to take out certain drugs that you just know you can't use for that patient. And then you're going to have a spectrum of drugs that would be the best drugs that you think, somewhat appropriate and within the realm of possibility. And what I try to do, and I really like, Elizabeth, how you started by saying, I try to present my patients with a menu. One thing that I try to say with my patients a lot of times is something similar, where I kind of say, okay, I'm going to give you the full spectrum of options that we have, but you're the quarterback in this game, or you're the captain of the ship. And I really want you to be the one to help guide us to where we go. And I'm not going to throw medications at them that would be inappropriate. I'm usually going to give a realm of possibilities. And there'll be some patients who are really ready to go very aggressive in therapy at the get. There'll be some patients that are not wanting to be all that aggressive. And I try to kind of, there'll be sometimes there's just one drug that's the right one, but I try if there's an option to kind of say, here's the least aggressive, medium aggressive, and more aggressive, and give a very short little quip about each of those, and then a little bit read the room and read both their face and their response. Because sometimes you'll say the more aggressive med, and you'll see this, and like take a step back, and you're like, okay, I know they're not there. I know we're gonna have to stepwise get there. And then you'll see other patients as you start talking about topicals that they're like, I don't want to fap about with that. I've been dealing with this disease for a really long
Mhm.
period of time. Get me clear. And I think very quickly you can get the sense of where a patient's at with, I'm ready to jump to a systemic, or I'm in the topical space, or somewhere in between. And that then allows you to kind of gauge and dive into the drug of choice for them. So you're going to be picking some drugs, you're going to be going at the ones that you think are most appropriate. And then there's times that you're going to guide the conversation where you really think this is the most important med for them. And then I think feeling really comfortable with how you present that information in a speedy but understandable way is really the art of these conversations.
That's so true. And I often talk with patients, there's the science of medicine, right? And then there's the art of medicine. And this is one
Mm-hmm.
of those things where that artistic license really comes in, and being able to analyze what a patient wants, that's a true skill that clinicians have of, as you're getting feedback, further in your mind, kind of sorting through our choices.
Mm-hmm.
And sometimes I even like to say to patients, tell me what is the most important thing. Is the most important thing to you the fact that like the medicine has been out for a million years and it's been studied and it has the number one most safety studies? Is it important to you that it comes in a pill? Is it important to you that you only have to take it once a month? Is it important to you that, you'll do anything as long as you get better as fast as humanly possible? Does it matter to you if you have to get labs checked? And sometimes asking those questions, like you were saying, that infinite list that we have in our minds, which thankfully is so much longer than when we both trained, where we had like a small handful of options that had a lot more side effects than the options that we're thinking about now. And so I think that all of those things are ways that we can listen, but then also share. And I love what you said about that first paragraph. I think that's a great way to say it, is if we can just keep our lips zipped through that first paragraph and don't ask any questions until we let them get out, why are you here? And what's the most important thing you think I can help you with today? That's so important. And I also think, Barry, I'd love your input in your clinic, because we are a team, right? We all have
Yeah.
different team members. We have other clinicians, we have medical assistants, and we have, it's an entire team. Barry, what are some of the ways in your clinic that you make your clinic as efficient as possible?
I would say so. The first thing is when, as medical assistants, I think it's really important, especially because a lot of medical assistants scribe now. So I think that it's really important is what we do to make sure that we're going above and beyond to really learn what it is we're asking, because I think that's what makes it key for providers to be able to give the best care. Because again, like you said, you guys are dealing with high patient volume, you're trying to get in and out, but you've got a patient here who's, seen multiple dermatologists, tried multiple topicals, and they're just ready to get their skin clear. So I think it's important that the medical assistants are trained enough to know to ask those specific questions, because then it takes that out of your mind once you're actually speaking with the patient. They've already tried three or four, different topicals. They've tried a calcineurin inhibitor, for their atopic dermatitis. So getting all of that information right there starts the process, at least for you as providers. But then I also think it's important to make sure patients, so I'll get an HPI on a patient, I'll have everything ready. But then I also, because of my knowledge, I help providers in that way. I know what the latest data is for certain biologics. And these are things that aren't hard to learn. They're just a part of our everyday knowledge that we have to do as medical assistants, because again, when we're sitting down and we're doing those prior authorizations, these are the questions that they're asking in those prior authorizations. So having all of that information beforehand makes it a better experience for the patient. So after you've had that conversation, you've given them this information. And then I always like to end it with, once the provider steps out, that's where my role comes in again, because here's my email address. That's the first thing I'll give every patient, especially if we're starting them on a biologic or some sort of a systemic therapy, because they're going to have a lot of questions. And the biggest reason that a lot of patients won't start therapy, even though this is debilitating, is because they're really overwhelmed. So I've had so many patients that are like, God, this is a lot. I don't know if I want to do this. Like, I'm just going to stick with topicals for now. But it's like, if you give them that open access to be able to communicate with you, they will email you and ask you questions, and you can answer those questions for the patients and make them feel more comfortable. I think is the biggest thing for me. And I think that in turn kind of goes back into that continuing education and knowing exactly what it is that you're prescribing. And, I let patients of color know when a provider picks like Dupixent or Ibglis or Tremfya, just off the top of my head, I let them know. If the provider doesn't, because again, you guys are so busy, sometimes you can't always get it all out there. I'll say, they've done trials for patients of color, and the efficacy of this drug is really great. That's the big one that 9 times out of 10, when a Black patient hears that, they're going to want to jump on board because, again, it's about connecting that trust. So letting them know, hey, wow, not only is this drug doing these things that makes me feel like I'm in a safe space, this provider has this knowledge, which is even putting me more in a safe space and kind of breaking that gap. So that's something that I think is really important when prescribing those drugs, is letting them know that they work for them.
Yeah, absolutely. And I think specifically, as we know from a representation perspective, we need more dermatologists of color represented. And, that is something that the Skin of Color Society is actively working on, representation in lots of different forms, from pathways programs and many things like that. Dr. LaChance, when you're thinking about, overall satisfaction for your patients and incorporating perspectives and diagnostic accuracy, or even like as you're maybe teaching, a new student, what are things that you think about specifically in a skin of color population that are important to you when you're thinking about treatment adherence, satisfaction, outcomes, things that you want to make sure that you say and that you want to make sure that you don't miss?
A lot there in terms of the teaching. I want to comment, and then we're going to pivot into the kind of how you get to those best outcomes for patients
You
with
do
skin of
you, girl.
color.
I love
But
this.
no, when I was like, when you were saying, I want to comment on the representation aspect, because I think that's so key when it comes to making sure we improve those outcomes for patients with skin of color. And it's representation in not just providers who are, racially and ethnically matched with their patients, which definitely we have seen helps patient outcomes and helps patient care. But I think to Barry's point is making sure that physicians and PAs and healthcare providers across the spectrum feel very comfortable diagnosing a disease and not missing a disease with a patient with skin of color. So I think now we've started to learn more and more about the disparities that are out there in terms of representation in images and textbooks, in publications, in slide decks. And so I try to be super cognizant when I'm building my slide decks and teaching about inflammatory skin disease to say, this is how this disease looks across the spectrum. So that in terms of improving outcomes, one of the most important things there is making sure for the first place, we're diagnosing patients appropriately. And then I think not just how do we diagnose, but also understanding the difference between activity for patients with skin of color, because a lot of times in inflammatory skin disease, we define activity by erythema or a violaceous hue or color change. And detecting subtle color change in patients with skin of color is very important for us to all have an eye on, because I have seen multiple times someone being sent in and being either told or someone misinterpreting and saying, oh, but their disease is burnt out. And you're like, their disease is not burnt out. Their disease is active. This is active disease. We have
Yes.
to treat the inflammation that's here. And understanding that, for instance, for psoriasis, if you stop a derm resident on the street and say, what does psoriasis look like? They may say a well-defined salmon colored plaque with fine, thick silvery scale overlying it. Well, salmon colored is only salmon colored in certain very light skin tones. As you look kind of across the spectrum, it can be an orange hue, it can be hyper pigmented, it can be kind of a light dusting of pink, but yes, you're going to have well-defined plaques with overlying scale in very common areas, and knowing those hotspots, knowing how dermato looks, how psoriasis looks, and knowing the things beyond the color that's traditionally labeled in textbooks is very, very important. So I think that's where we start, is diagnosing patients appropriately and having that representation, across the board. When it comes to outcomes, I think one important conversation to have with patients with skin of color, and with all patients, is gauging expectations and making patients understand what your goal is for treatment. So for certain diseases, it's getting their skin clear. For other diseases, it's stopping disease progression. And once the damage is done, we cannot reverse that. And I think it's really important to have those conversations up front, because if a patient is expecting one thing and you're expecting something else, that's where you're going to start to see patients dropping off meds. And to Barry's point, having a way that they can reach out to you when they need and saying, these are the most common side effects we see. If you have these, I want to hear from you because there's things I can do about it. And not if you have them, I want you to quietly slip into the sunset and never come back to my clinic, because I think you
Yeah.
want them to know that you're accessible and available to have those combos. And if this isn't the right drug for you, we can switch to something else. And that's one thing I try to say for any of my patients that have some hesitancy around starting a systemic or a biologic is, look, if you don't tolerate this, if you don't like the med, if we don't get the outcome we don't are expecting or hoping for, we're going to switch therapies and we have other options. And I think patients knowing we have options, knowing where you're going, knowing what the end game is very, very important, so that you all can marry and check in on those expectations. And I say, I'm going to check in on you at this time point, and at this certain time point, here's what I expect. So for instance, connective tissue disease, I may start someone on methotrexate. I might see them back in 6 weeks. I do not expect the drug to have kicked in at that point, but I want to see how you feel. And then I'm going to see you back in 3 months. That's where I'm hoping things are really starting to kick in. And so gauging that with patients, I think, is very important. And then the other thing that I'll just say, specifically for our patients with skin of color, post-inflammatory hyperpigmentation is a huge aspect of treating inflammatory skin disease, and letting them know, look, when we stop disease activity, you may have kind of a shadow or a hue, especially because you have some pigment in your skin and you have more pigmented skin. I'm expecting you to have a kind of a shadow left over of where you had inflammation. That will improve with time, but that's going to lag behind that inflammation. And that can take months to a year to get to the goal
Mhm.
outcome. And having a patient know that when that PIH is there, it doesn't mean that's it. That's all, oh my gosh, I'm not seeing the expectation I want, but kind of gauging and managing expectations around that is huge, because we know dyspigmentation is one of the most important things for our patients with skin of color when it comes to goal outcomes.
Yeah, I think that I love the way you brought in the hyperpigmentation at the end, because for so many of our patients, you know, sometimes if we take acne, for instance, they're not actually bothered by the active acne lesions. They're bothered by the footprints that the
Mm-hmm.
active acne lesions are leaving behind, and sometimes perceiving those as scars.
Mm-hmm.
And even though in clinic, we're always thinking about those hyperpigmentation spots and we're always thinking about those scars, sometimes we don't do a great job of saying that out loud to the
Mm-hmm.
patient.
Mm-hmm.
Hey, I'm making this choice for your acne because it will help work on your active acne as well as the
Mm-hmm.
hyperpigmentation spots, which I know really bother you. And
Mm-hmm.
I think that's something that as clinicians, we need to do a better job at saying, because we're all thinking it. It always goes in our note, right? Because we're thinking about it because we know how important it is, but sometimes we don't verbalize that. And then sometimes going back to initially what we were talking about, if we don't verbalize that, then the patient doesn't feel heard.
Mm-hmm.
And so I think that, it brings me to kind of that what we've been kind of talking through almost this entire time, which is the true shared decision making process and what that looks like. And sometimes I'll say to my patients, hey, like this is the menu, and like this doesn't ever like this doesn't go off the menu. Like if you're not ready to make a decision today, we can revisit this. And Barry, I love how you shared that you give your email address. I think having a biologic coordinator is such a gift, in any practice. And it's so wonderful to have, someone who is set up to answer those questions and be available for patients in that way. It's so great. Dr. LaChance, I'd love you to talk through, just give the audience an idea of what we mean when we say shared decision making, because we've been talking about it a little, but we haven't really named it. And so, this concept of shared decision making, why we think it's important, and just kind of tie the bow on that for me, because then I have a couple other things I want to dive into with regards to research.
Yeah, I think we've moved beyond the paternalistic, this is what you're going to do, and move, and on to the next patient, you know, time of medicine. And I think shared decision making is when, you know, you are bringing to your patients treatment options that are appropriate and effective, and then allowing then for the patient preference and goals to really color and shape the decisions that you're making, and I think together, if we get to the place where that conversation feels guided by that patient preference, guided by the patient goals, then a patient is going to leave your office feeling empowered to move forward and excited to move forward. And you're going to build that trust that's going to allow for a productive relationship in the future. And I think so. Shared decision making is when you are getting to a treatment, plan that feels congruent and concordant by both the physician and the patient. Sometimes easier said than done. Sometimes it's a journey to get there. Like you said, Elizabeth, the menu we may revisit multiple times. But I think making sure that, the things we're picking are appropriate, but that patient voice is coloring the conversation all the way through.
Yeah, absolutely. And I think that the patient engagement is so important, but sometimes it's easier said than done. Sometimes when we're asking patients, like they're sometimes they haven't never thought about that question, or they're not certain what is most important to them when we ask them what's most important. And despite our best intentions, barriers still exist. And there's even data to say, when the doctors explain things to the patients and think they did like a 10 out of 10 job on sharing all the options and having great shared decision making, then the researchers went and they asked the patients, how well did the doctor do? And the patients didn't score the doctors quite as high as the doctors had scored themselves on the shared decision making process. And so I think just being aware that this is an area of opportunity and how important it is, and that we still have room to like grow and learn because these barriers exist. And so, Barry, you were sharing a story with us before we started. But I'd love you to talk through, some conversations that you've had with patients and any of the more common obstacles, if you will, that prevent patients from feeling empowered in their care. And what are things that, from your perspective, that you see that a clinician might do to help address those barriers and make their patients feel more empowered?
I think that the greatest thing that I've seen providers do is making sure when you're discussing these, kind of the menu, as you say, with the patients, is not making a point to just throw a whole bunch of pamphlets at them, but like providers actually making, I don't know if a lot of you make your own protocols or handouts for your patients. I think those are the key thing for patients to help them when they're given so much information, is making sure they have something to leave with that isn't going to confuse them. Because that's also the big thing with a lot of the things that we hand patients, is like the medical jargon and the things of that nature. They don't understand what any of that means. So when you put things in kind of simplified terms, I think that's a really great way to help patients be able to understand what they're getting. And the biggest thing, what kind of started this whole journey for me was a provider had left the room, and I had a patient who was type 5 skin. She wanted to know, does this drug actually work for me? And I had no idea. So I had to kind of reach out to the pharmaceutical rep for the drug, and then they got me in contact with the medical liaison, and then I was able to get clinical trial data. And I was like, wow, oh my God, I didn't know any of this. And at the time, a medical assistant, I was biologic coordinating, but not to the capacity to where I am now, where it's like 13 providers by myself kind of thing. But you really do learn how to kind of navigate what patients need based off of that. So that kind of inspired where I am now. And also, it's also to what you put in your chart notes. I think that's the most important thing. Once the patients leave the room, I think, and I know we're going to get into research, but a lot of these drugs, they're based off of clinical trial data endpoints. So whatever things they're finding as a result of these trials, they're then having those be the questions on the PA. So I've learned to not only tailor my responses to that, but also really making sure that we emphasize in these notes the pain that these patients are experiencing. And kind of to Dr. LaChance's point, when we talk about the hyperpigmentation and that the psychosocial burden of this is really important, especially for, deeper skin tones where, it carries a significant cultural weight for Black patients with the hyperpigmentation and the things they deal with after. I am such a big person of like, document, 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 document every single thing. But most importantly, like it is like when we deal with patients with HS, making sure that we're not just hitting those early stages, but that we're also hitting how debilitating this is for the patient, everything they've gone through. Sometimes I put things in chart notes that probably are a little TMI for insurances, but it's those small things like that that get things approved. So I think that all kind of encompasses making sure that the patient's getting taken care of, both in the room and out of the room. Um, and then in the end, that patient that I spoke on, she actually wound up going with the drug simply because A, the data was great, but then also because they did a trial focused specifically on that. And so it warms my heart when I hear things like that.
Yeah, and you bring up the really important point about representation. It goes much beyond the clinic, right? It's critical in research, it's critical in advocacy, it's critical in our education. And how, Dr. LaChance, this is something that I know you and I spend a lot of time, talking about the importance of diversifying research and clinical trials and how do we encourage, the demographics of the clinical trials to reflect the demographics of the patients that we serve. And what are things like, how do you think dermatologists can best support greater representation in these areas?
I think first is awareness and having the conversations in the first place. I think that's really key and critical is to not just say, hey, we're recruiting for this trial. Let's get a whole bunch of 50-year-old white men to do the trial. And like, because those are the first, people that said yes. And I think kind of having an awareness of saying, okay, we want to make sure we're having representation across the spectrum when it comes to gender and racial and ethnic backgrounds, and saying, all right, we're recruiting for this trial. Let's keep an eye on that to be as representative as possible, and making sure we're offering trials to our patients, offering systemics to our patients. And on the research side, I do think the thing we have to be wary of, and one thing that I think is really true, is a lot of our patients with skin of color are hesitant to join a clinical trial because of the historical, um, you know,
Of course.
egregious trials that
Mm.
have happened in communities of color. And so I think that's understandable. And being ready to have conversations with patients across the spectrum about, the safety data, B, why we think that's an appropriate trial for them, and then also hearing their fears and concerns. And then, of course, you never want to coerce a patient into a trial, and being very, cognizant of and listening to a patient when they say that's not for me. So I think that's why I really applaud a number of our different industry partners who have said, exactly to Barry's point, we want data specifically for our patients in skin of color. And this is a trial for patients with skin of color. And that's why a lot of those trials are important, both for our representation in um, materials that we can show our patients, data we can show our patients, but then also saying, hey, this is a trial designed for you, and then we'll shape and improve the care for other patients, with pigmented skin. So it's a fine balance between saying, let's make sure we have the representation, but also making sure we're being very respectful for understandable distrust in that trial space as well. Barry, I'm curious your thoughts in terms of how those conversations have gone in your practice also.
Well, and I was gonna say, I can't tell you how much I appreciate the things that you're saying because I think this is what this is all shaped off. You have to start having these conversations, albeit uncomfortable for some, especially when we start talking to pharma and things of that nature. I think is as MDs and as PAs, you have so much power. Your words mean so much to these companies because you're the ones that are prescribing these drugs for them. But I'm also realizing that we all are finally, especially biologic coordinators, we're getting in this space where we're actually having a little bit of power to be able to have these conversations and affect change. I've been so surprised by, because I go and I give these presentations and, pharma's coming up to me and saying, wow, this is a really powerful statement that you're making. And wow, normally only providers have this data. Where did you get it from? And it's like, well, because I do my research. I really want to make sure that when I'm putting things out there, it can spark change and it can inspire those conversations. And, the biggest thing that I'll hear in some of the clinics that I worked in here in Washington is, or when I talk to providers at different clinics, they'll say, well, I don't really have a high population of patients of color or like type 5, type 6 skin. So I don't really know that much about it. And so my rebuttal to that is always, well, that means that you should definitely even more so know so that when these patients do come into your clinic, you're prepared and ready to go because this starts that domino effect of how misdiagnosis happens because they're not very knowledgeable on what's to come. And I just think that, you know, I I think it's just taking your power and putting it where you can. And again, this is why I always love having these conversations with MDs who are aware of the past and what's happened with mistrust, but are also right there at the forefront, really trying to help shape these things. These are some of my favorite conversations to have with providers and also wanting to encourage other biologic coordinators and medical assistants to become more aware of what's happening in the world of derm, especially, ones that have been doing this for 10, 15 years. You hold a lot of power in your knowledge as well. Providers look to us too. So again, I think it's all just this. I think what we're doing now is what's going to help shape the future and help shape the future in my clinic is having these discussions, making these pharmaceutical companies more aware of what change needs to happen, and then it just continues to push the needle forward.
Yeah, I think we, have to continue to say things out loud, and it's feels like we've been talking about it for so long. Some of
Mhm.
us in the, and certainly those of us on this call, but it does feel like there's momentum now, and it feels much different now than when we were having these same conversations 5+ years ago. And so, in closing, I want you both to think about, what's an action step? Specifically Dr. LaChance for clinicians, and Barry, I want you to think from the perspective of patients, but what's one action step that you think clinicians and patients can do to better incorporate their voice in the shared decision making process? And when we're, trying to drive meaningful change and trying to help patients like lift their voices, what are things that, you can share that would be a pearl of like if everyone maybe could just do this or could ask this or could share this resource or could, what is an action step that you'd like to leave our listeners with?
I think the letting your patients get that first paragraph is a lot of gold. And, I think that's an important
Yeah.
one. And then you can be buzz, 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 speed, speed, speed from there. Um,
Yeah.
I think is number one. I think number two, be prepared for any of your patients, and specifically, I think more so in our patients with skin of color, to take a stepwise approach when that's where the patient's at. So meet your patient where they're at. And a lot of times having that first paragraph will be the first place, to get started with that. And I think three, push yourself to continue to think about how we improve care for our patients with skin of color and improve equity by forcing yourself to say, where are my weak spots? Where do I feel uncomfortable in terms of diagnosis? Where do I feel uncomfortable in terms of data? Where have I not gotten patients into trials where I need? And then make an action item to move forward in that direction to improve your understanding and make sure that as you educate and then you teach, that you're encouraging others to do so as well.
That's so amazing. And this is truly everyone the definition of Dr. LaChance. You ask her for one thing and she gives you three that I'll knock it out of the park. But I really think, especially that last one, just having the humility
Yeah.
to say, I can do better. Maybe I can learn more. Maybe there's something I'm not doing, and so I'm going to investigate that. Barry, would love to know your thoughts or any action items you'd like to leave our audience with.
Well, and my biggest one was going to be exactly what Dr. LaChan said, which was the listening aspect of things. And I think it's also getting out of that discomfort because like I've always been told, like once you push past that discomfort, that's where the healing starts. So I think that's the biggest thing to say, not only for us and expanding and learning our knowledge, but I think also for the patients. We have to push them past that distrust and that feeling of angst because on the other side of that is where the healing begins. And I think that also that same statement works for the pharmaceutical companies because I think for a lot of people, for a lot of clinicians, a lot of this lack of diversity, a lot is probably a lot of uncomfortability in having these conversations. And so we have to move past that. And I think also just having the resources set up for all patients, of course. But I think it's also when we're dealing with patients of color and we're dealing with patients like that, that we just have all of the right information for them on that initial visit because that initial visit is everything. That's going to make or break how you're dealing with your patient. So again, that's why I always say having handouts that are tailor made for the patients, making sure to listen to the patients, making sure to give them access to you, not specifically to you guys because we know you're busy, but access outside of that visit. That's another key thing for patients, especially a lot of these immunosuppressant drugs. Obviously some of them carry side effects, the JAK inhibitors and things of that nature. So we just have to be prepared, I think is the biggest thing. And be prepared to give the patients a little bit more time than that 15-minute window that we have. And if you providers feel comfortable enough in this, I think it's also allowing your medical assistants not to go beyond their scope of practice, but for them to be knowledgeable enough to be able to answer those questions for you that you can't do because you've got to get out of that room. So that's one thing that I do with every medical assistant that in every clinic that I work in is I empower them because if I empower them, that's going to help the patient, that's going to help you. So I think that all works in the realm of making sure that giving the patients a voice in their power is that everybody's involved, not just the provider. We all play a role in this together.
Yeah, that's so perfect. And, really what we're talking about today is the true role of patients as partners in advancing dermatology equity. And
Yes,
so this has been such a fun conversation. Thank you, Barry. Thank you, Dr.
yes.
LaChance, for sharing your insights and for just really this important work that you're both doing. And I just encourage everyone that's listening is it's never too late to start. And, always there's something we can do and learn and do just a little better tomorrow by what we learned today. So to our listeners, we hope that this Savvy Conversation episode encourages you to reflect on how patient voices can shape and improve the care you provide. To learn more about the Skin of Color Society and its initiatives, please visit skinofcolorsociety.org. Also, be sure to follow Skin of Color Savvy for future conversations centered on advancing equitable dermatologic care. Thank you so much for listening.